Good afternoon, everyone. Time to start our session. Sorry for the slight delay. This is a illuminating session, as you've seen from the title. We try to cast some light on the night, see what happens for our patients during the night, how can we identify their problems and protect them. And this meeting is co-chaired by Professor Stergiou from Athens, and my pleasure to introduce him actually to be the first speaker, and he will tell us something on nocturnal hypertension, the hidden risk and how to assess it. Please, George.
So I believe, ladies and gentlemen, we discussed several times in this meeting about nighttime blood pressure. And here we'll talk about that again, the hidden risk and how to assess it. And these are my disclosures in relation to this presentation. So we know that long time ago. This is the Pamela study, 20 years ago. And you can see the predictive value of different methods for predicting death. This is office blood pressure, the worst, daytime blood pressure, ambulatory, home, 24-hour, and nighttime blood pressure. We know for 20 years it is the best aspect of the blood pressure profile in predicting the risk of death. And this is 2020, and after 20 years, we got these impressive results from a huge database from Spain, 60,000 people, 10 years follow-up. And you can see here again the risk of death. This is the association that office blood pressure provides, daytime, 24-hour, and again, nighttime blood pressure, with relatively few readings, much fewer than daytime, is the strongest predictor of death. And if you look at the information of this which is provided by this method, you can see here that in terms of all-cause death and cardiovascular death, nighttime blood pressure gives 6-fold more information than the measurements we take in the office. And Gianfranco Parati led a paper which is now in press, trying to summarize all the knowledge we have today about nocturnal blood pressure, and we know a lot. And he presents the mechanisms which influence the nocturnal hypertension and non-dipping, which is related to sodium and water handling, the renin-angiotensin system and autonomic nervous system. And it's really a complex area. In another paper a few years ago, we also discussed that there are other players as gut microbiota which might interfere to the nocturnal blood pressure level. And you see how interesting is this topic. Europe published this, actually not European, but international paper on nocturnal blood pressure. And there is another publication from the Asian Expert Consensus, and this is a few weeks ago. And in that paper, they define nocturnal hypertension as blood pressure elevated during nighttime sleep as higher than 120/70, average of few readings, defined using classic ambulatory monitoring or home monitors, which I'm going to present later. And they discussed the concept of isolated nocturnal hypertension. It is a type of mass hypertension which is impossible to identify unless you have nighttime blood pressure measurement. And this means that you have nighttime blood pressure elevated, but daytime is low. And we'll come back to this condition later. And they highlighted the point that in Asia, they have much more nocturnal hypertension compared to Europe. And there are several studies showing that, and this is supposed to be related with the excessive salt intake and salt sensitivity in the Asian population. This is the most important part of my presentation, which changed the way I think about nighttime blood pressure. This is a paper which was published again a few weeks ago. It is from the same Spanish registry, and they looked at different types of mass hypertension. They had 15,000 people with low office blood pressure, and 10,000 had normal 24-hour blood pressure, so well-controlled or normal intensives, and they ended up with 5,000 people with mass hypertension. Mass hypertension when? During daytime, nighttime, or both? Interestingly, 60% of people have elevated blood pressure during daytime and nighttime. 16% had only daytime, and 22% have blood pressure elevation only during nighttime. Which was the risky condition? So if you have mass hypertension driven only by daytime measurements, no problem. Look at the all-cause mortality, not significant. Look at cardiovascular mortality, not significant. As long as nighttime blood pressure is normal. If nighttime blood pressure is elevated, irrespective of what is happening during the day, isolated nocturnal or daytime and nighttime, it's a high-risk condition, which means mass hypertension is bad only if nighttime blood pressure is elevated. That's the problem we face, the hidden risk. So we have agreed for several years that this is the best method we have to diagnose hypertension, 24-hour ABPM. And these are the recommendations by this society for nighttime hypertension BP phenotypes. The ESH says that you have to assess nighttime blood pressure using BPM because it is more predictive for outcomes than daytime blood pressure, and that nocturnal hypertension, non-dipping, reverse bleeding are all associated with increased cardiovascular risk. But they also say that if we want to identify nighttime blood pressure phenotypes, 24-hour ABPM is not enough, because our sleep is not reproducible. So they say if you want really to understand what's happening during the night, certainly you can't do that within 24 hours. And the ESH says frequency measurement 20 minutes during the day and night. This is very important because nighttime is a short period, and if you go for 1 hour readings, you end up with 4 readings or 3 readings if you miss any of them. So it is important to have the same frequency, 20 minutes during the night, to have a decent number of readings. We have been using 20 minutes day and night for 30 years. Gianfranco, who is a fan of variability, he is making 15 minutes readings for many years. If you are going to have problems in BPM, it's not because you have 15 or 30 readings, because the patient does not like the method in the first place. And they also highlighted the issue that high-risk populations, diabetics, and people with chronic kidney disease, you need to look for nighttime blood pressure. It's particularly common in these high-risk populations. ESC, very nice plots. User-validated device. Here, they say 15 to 30 minutes intervals during the day and 30 to 60 at night. I think this is wrong. A minimum of 70 readings usable is required, which is the same in the ESH, a diary with activities and the wake-asleep time, and the thresholds. I think you should follow the ESH recommendations, 20 minutes intervals, particularly during the night, because it's a shorter period. ABPM is an expensive device. I don't really understand why ABPM is so expensive. Can you use a low-cost home monitor? Well, yes. We know that 25 years ago, this group of Japanese colleagues developed this Omron device in 2001. A low-cost home monitor with change in software, and you can activate it before you're going to bed, and it takes automated blood pressure management during sleep. And this next generation is a wrist device aiming at less interference of the cuff inflation during sleep. And it's in 2019, we published this paper with several colleagues, including my co-chairman and leading author Keiya Sayama from Japan, and specifically for nighttime blood pressure detected with home monitors, low-cost technology. And this is a paper from Japan. This is the Association of Nighttime Ambulatory Blood Pressure with albuminuria and left ventricular mass index. And this is the same for home blood pressure nocturnal. And why it should be different? It's nighttime blood pressure, after all, with an automated device. And this is another study we did in children. And you can see here ABPM, nighttime ABPM associated with cardiac, arterial, and renal damage. And this is, again, nighttime blood pressure with home devices. No reason to expect a different association. And these are our colleagues from Japan who showed that ABPM is great to define nocturnal hypertension, which is associated with worse risk. And if you use home monitors, maybe you can do even better, or at least as good. So another low-cost technology for wide use for assessing nighttime blood pressure. And you can see here the wrist nocturnal home monitor by Omron, which has this important advantage. You can see sleep disturbance. With the upper arm cuff, 24-15, with the wrist diagram device, 1-4. So this is the main advantage of this technology, which substantially reduces sleep disturbance due to cuff inflation. And Omron has developed also this smart technology. It's again a wrist cuff oscillometric device, but it's more sophisticated with a thin cuff to inflate, and you could use it for nighttime blood pressure. And this is a new type of devices which we can use, and we have to understand them better. And of course, we have the cuffless devices. We had several discussions about them during this meeting. They see that blood pressure goes down during sleep, but it doesn't quantify the exact magnitude of the asleep blood pressure change. And this is why this society does not recommend these devices for clinical decisions, as well as the European Society of Cardiology. So nocturnal hypertension is a problem. We have been convinced it's important. How to assess it? 24 BPM. First, it disturbs sleep. Second, it is only one night, which is not reproducible. Home blood pressure wrist, it disturbs sleep less and gives us information from more nights. Cuffless wearable devices, not yet. Wrist cuff wearable devices, limited data from another challenging technology. So this is my final slide, which is copy-paste from the Asian expert consensus, and shows the challenges we have to face when we want to define, diagnose, and manage this condition, nocturnal hypertension. We need to develop low-cost devices for wide use for assessing nighttime blood pressure. We need simultaneous monitoring of sleep quality to make sure who are the non-dippers and non-sleepers. And we have to investigate the association with disrupted circadian rhythm of blood pressure. We have to identify high-risk people who need strict nocturnal hypertension management and have to understand and design pathophysiologically based treatment for specifically targeting nighttime blood pressure. Thank you for your attention.
Thank you, George. We have the discussion at the end. So if you want, you can introduce the next speaker.
So the next speaker will talk about the better you sleep, the more you dip, of course. Grzegorz Bilo, here from Milan.
From here. Thank you, George. As you see, the title of my talk makes even a little rhyme, and that's my disclosure. I'll be talking again about blood pressure at night, but looking at it somewhat in a somewhat different manner. We've been talking about the level of blood pressure during the night, but we know that day and night is different, and that there is a change in blood pressure between day and night, which has been identified several decades ago. When this change was identified, the term dippers, non-dippers was coined, meaning that normally your blood pressure will decrease during the night by at least 10%. Let's say that fully normal range would be between 10 and 20%, while there are people who are non-dippers, so people in whom this decrease during the night is smaller. And you can be hypertensive dipper, you can be hypertensive non-dipper, but you can also be normotensive non-dipper. The two principal categories were first defined with a cutoff of 10% decrease in nocturnal blood pressure, and then further subclassification was proposed with a subgroup of risers, so people who have higher nocturnal than diurnal blood pressure, and extreme dippers, those who drop more than 20% during the night. And as I said, you can have different combinations with nocturnal hypertension. These two phenomena are linked. Dipping is very dependent on foremostly on nocturnal blood pressure, less on diurnal blood pressure, but you still can have people who are non-dippers with normal nocturnal blood pressure and can be reverse dippers like this here with maybe normal diurnal blood pressure. So there are different possibilities. So what causes non-dipping? Many things can. Here you see an example from our studies at high altitude. The three graphs that you can see represent three different altitudes in the same people. It's an average of about 50 people, 25 people. And as you can see, at the bottom line is at sea level. This is intermediate altitude, 3,400 meters. Then when you go to Everest base camp at over 5,000 meters, your curve will look like this. So what you can note is that blood pressure increases, but it mostly increases during the night. So actually the dipping is reduced. It is reduced. Why? We are not completely sure why. Probably because you become more hypoxic, but also probably because you sleep worse. In this condition, sleep quality is impaired. So among different determinants that underlie the nocturnal blood pressure fall, we can look at several physiological mechanisms. We can identify several pathological conditions that can be associated with this condition, but we definitely should look at sleep. And among different sleep-related factors, there will be also sleep quality. What is sleep quality? Well, we can look at it as a something subjectively reported. We have tools to measure that. We can look at it in a long-term scale, so over the past months, like with the Pittsburgh scale. or we can look at just the past night, which is maybe what will be more interesting in this talk. Again, we can have a question on that, but you know, questioners have their limitations, so we prefer obviously objective assessment. Objective assessment can be done with less accuracy with actigraphy, with more accuracy with polysomnography. And from that you can derive different parameters, sweep efficiency, so latency, how much time you get to get sleep, wakefulness after sleep onset, so how much time you are awake after you've fallen asleep once. Sleep macrostructures, how much deep sleep, how much REM sleep you have, and sleep microstructure, so whether you have arousals during the night. Now, when we think about blood pressure and sleep, there are several questions we can ask ourselves. So one, is there actually a relationship between sleep quality and dipping? And then we need to ask questions about our conventional measurement, that is ABPM. Can it really affect sleep quality? And can it affect dipping? So do we need something else? So let's try to answer these questions. So does sleep quality affect dipping? The response seems obvious, and yes, it does. This is one example showing the correlation with Pittsburgh score, with other elements characterizing sleep quality in a subjective evaluation, and as you can see, all they are related to dipping, or at least most of them. But also, if you measure it objectively, these are the data from Wisconsin Sleep Study, one of the largest cohorts dealing with these issues, and you see that there was a significant relationship between WASO, between sleep time and sleep efficiency, which is the proportion of time spent in bed when you actually sleep. And all this was associated with dipping. Now, what happens when you put a classic ABPM on a patient? Well, all of you who deal with this method know that many patients complain about it. They will come back and tell you, I won't put it again because I didn't sleep. This is our clinician's perception. And if we think about it, we are dealing with a kind of Schrödinger's cat. You know this concept from quantum physics that unless you did the measurement, you don't know the spin and the position of a particle. But once you did the measurement, the cat dies, and you have no information on what happened before. And same thing could happen to nocturnal blood pressure. If the method you are using affects nocturnal blood pressure, then you might be measuring something imprecisely, at least. So does ABPM affect sleep quality? When you look at objective sleep quality, actually there is little data because it's difficult to do polysomnography and ABPM both. But for example, in this quite recent study by Socrates, so George knows the person, there was actually no difference in the characteristics in the number of arousals or sleep efficiency. This was done with actigraphy, so less accurate method. And old studies from Milan group showing that when you do automatic inflation, you actually, when you're awake, you do not increase blood pressure. On the average, there is no hypertensive response to cuff inflation. And when you, this was a study cited also by Professor Mancha this morning. This was a very, let's say, sophisticated study, so it's a small sample, but interesting, because it was 48-hour recording with intraarterial blood pressure monitoring, and 24 hours out of this 48 were also with oscillometric ABPM. There were no significant differences in blood pressure and in dipping. So in this small group, actually, conventional ABPM did not seem to affect dipping. Then the largest probably study on this topic is by Paolo Verdecchia from the Puma cohort, and they identified, this is not a very precise evaluation of sleep quality, but they asked people how long they slept compared with their normal standards, and they found that those who reported sleeping with ABPM on shorter by at least 2 hours compared to their normal, tended to be less dippers. And interestingly, these people, when they were non-dippers, this status was not associated with cardiovascular risk. We know that I didn't repeat all this data showing that non-dippers are at increased cardiovascular risk, but in non-sleepers or poor sleepers, this is not true. So the alternative, we are here to talk about home devices, and let's start with something obvious. People like home monitors better than ABPM overall. This is mean acceptability. The upper row is home, the lower is ambulatory, different studies, always the same. The score tells you the lower it is, the better they accept it. So there is a significant difference, and when you look at what is one of the most important components, you'll find that sleep disturbance is the major discriminant between ABPM and home blood pressure monitoring. So you have already seen that we may try and reconcile these issues. So we may get something that home blood pressure was missing. That is the estimate of nocturnal blood pressure while using a home device. So the night view is you have seen the Omron device, which is a wrist device, automated validated wrist device, which is programmed to typically to measure at 2 a.m., 4 a.m., and after 2 hours after the device is activated. So we get normally 3 measurements. And this is a meta-analysis from our Greek friends, looking at different studies, comparing the device, but also others, with the standard that is ABPM, nocturnal BP, and there was just very minor difference in terms of nocturnal blood pressure, in systolic blood pressure, no significant difference in diastolic blood pressure. So the absolute estimate was fine, and you have already seen the study from Japan showing that this method actually correlates well with cardiovascular outcomes, which is what interests us most. In our group, we recently ran this study where we included hypertensive patients who did office ambulatory blood pressure measurement, and they used both the wearable heart guide device, which is only suitable for daytime because it is manually activated, and also the night view for the night, but also for the morning, evening measurements. So I will show you some data regarding the reproducibility of dipping and the arousals. First, the impression of the patients. The patients were generally happy with the device. They found it easy to use, and the acceptance was good. But as we know, that's not enough. 80% said that it had absolutely no effect on their nocturnal sleep, which is quite different from ABPM. Then we looked in a subgroup of patients. It was not easy because we had to do a full polysomnography with this device and have a good quality data. So we have data in 14 patients on that. We looked at the actual arousal, so not just the quality of sleep, but very specifically if there was an arousal following the measurement itself. So the tracings were synchronized, and we looked at as reference what happened just before measurement, 10 seconds after, and 20 seconds after the measurement. And what we found that among these people, only one person had an actual arousal within 10 seconds after BP measurement, but this was following a sleep apnea. So probably not related to the device itself. Another issue with dipping, less so with nocturnal blood pressure, but mostly with dipping, is its reproducibility. We know that it is not perfect. These are the data published by Professor Mancha showing that when you categorize these patients according to their dipping, these are long-term follow-ups, and they very frequently switch category, to put it briefly. We looked at this aspect also in another study we are doing, just looking at 2 categories, dippers, non-dippers, and found, which is more or less in line with most studies, This is a short-term reproducibility, so it was within a few weeks at most. We found that about 1 out of 3 change category in such a short period. Why does this happen? One of the reasons may be actually the variability in the quality of sleep. We sleep differently on different nights. And this is an interesting study where they looked at the reproducibility of dipping, and they found that one of the most important factors was the difference in sleep fragmentation between different days. So obviously, the more it was fragmented, the less dipping there was. So this is something where the home devices have good potential, I would say, because when we look at our data, on average, they give you quite similar values on different days. The reproducibility between different days is not that good, which is in line with what we know. But we may expect that if you measure it on different days, you will get a better estimate. So I conclude saying that we know from the previous talk that nocturnal blood pressure, but also nocturnal blood pressure dipping, is an important predictor of cardiovascular outcomes. We know that sleep quality affects nocturnal blood pressure, dipping, and clinical outcomes. We know that we still have the 24-hour ABPM as a standard for diagnosing nocturnal hypertension and assessing nocturnal dipping, but we know that it is frequently poorly tolerated. And considered this, we can say that nocturnal blood pressure monitoring with home devices clearly has a potential for clinical practice, given that such devices, cuff devices, are validated according to current standards. They are clearly better tolerated compared to conventional ABPM and do not seem to interfere with objectively assessed sleep. And we know that they provide prognostically relevant information and have the advantage of the possibility to repeat the monitoring on different nights over a shorter or longer period of time. Thank you for your attention.
Thank you. We have the discussion at the end. Now it's my pleasure to introduce the last speaker, Professor Alta Schutte from Sydney, Australia. She will touch a different topic, navigating blood pressure measurement in AF care, which is interesting for anyone and also for the cardiologist.
Thank you, Gianfranco. These are my disclosures. Right, so we've had some really interesting talks about nighttime blood pressure and or nocturnal hypertension. And I hope this afternoon you're all still awake, though, because I think after lunch people tend to lose a bit of momentum. But what is important when we look at nighttime and 24-hour blood pressure is clearly the nocturnal hypertension profile is really very important. I know this was shown by George, and I'm glad that he showed this slide, because I just want to confirm here again the difference in the strength of the relationship between clinic blood pressure in black to nighttime blood pressure in blue. And this is with all-cause mortality. As was said, it's 6 times more value and informative. If you look at cardiovascular mortality, the lines are even more steep, right, for nighttime blood pressure and cardiovascular mortality. So if we look at this, it's very clear from several studies, long time ago already until more recently, that nocturnal hypertension is related to all-cause deaths and cardiovascular deaths. And if we then zoom in a bit, also in the results from the J-HOP study from Japan, is that nighttime blood pressure is not only associated with total cardiovascular events, but specifically with stroke events and coronary artery disease events. So very specific in terms of these outcomes. Another review on nocturnal hypertension showed that it's also very strongly related to heart failure. And several of the studies that were included in this review included this one study, for example, by Professor Cario, showing that nocturnal blood pressure or extreme dippers and non-dippers, as you can see in the red and yellow lines, are strongly associated with heart failure. This was also shown several years ago already in a previous study showing a non-dipping pattern is associated with heart failure. So that's another important outcome of nocturnal hypertension. If we, as you've heard, the topic is a bit about AF as well, atrial fibrillation. And if we now look at atrial fibrillation in itself, there's also some strong evidence for atrial fibrillation, and in these lines on these different graphs, it's by age group. As you know, that atrial fibrillation incidence is much higher with increasing age. So per age group, from the brown line down to those older than 50, you can see at all ages there is a strong relationship with cardiac hospitalizations, MI hospitalizations, and heart failure hospitalizations. So for AF, this is also important. Another study showed, and it's what I've mentioned before here on the left, is that AF incidence increases with increasing age, as well as the prevalence, and you can also see in terms of the deaths. So AF is also very strongly associated with all-cause death and with cardiovascular outcomes, as well as burden of disease. So if we then also look at atrial fibrillation and zoom in a bit into this Danish study, which is very interesting, finding also a very strong relationship between AF and independent of the index age in the different boxes is 45 years, 55 years as the index age for atrial fibrillation. It's always very strongly associated with the blue line, which is heart failure. And you will see the pink and purple lines is ischemic or any strokes. So the most common complication was heart failure for those with atrial fibrillation, followed by stroke and myocardial infarction. So once again, quite similar to what we see for nocturnal hypertension outcomes. And especially stroke and heart failure are quite key in both of these. So we know, however, if we just look at the association between blood pressure and atrial fibrillation, that hypertension is one of the strongest contributors in terms of risk factors for the development of atrial fibrillation, and that's why we know that hypertension develops from early ages onwards, but AF often have the onset only from later in life. And that's why also it would make sense, as was said in this recent paper in Circulation, and a collaboration between hypertension and screen collaborators, the AF screen collaboration on hypertension and atrial fibrillation. How can we do better screening for both of these conditions, as they are so strongly related in itself, but also in terms of outcomes? So the key risk factor for the development of atrial fibrillation is high blood pressure or hypertension. But now is the question whether nocturnal hypertension is a stronger predictor of atrial fibrillation than daytime blood pressure. And this very interesting study, which was already published in 2018, showed, on the right hand you can see it's quite a large number of participants, almost 4,000, and for 2,700 of these participants underwent 24-hour ambulatory blood pressure monitoring, and they had ECG data to determine whether whether there's a link between daytime or nighttime blood pressure and the development of atrial fibrillation, and clearly show here, interestingly, that there was no increased risk with nighttime blood pressure and AF development, but for 24 hours, there's a 27% increased risk for AF, and then 22% and 20% for daytime and nighttime. So overall, blood pressure is important in terms of atrial fibrillation risk, with not necessarily for nighttime having an increased risk, as we've seen for many other conditions. And there is obviously a very strong relationship. If you think physiologically, what happens when you have high blood pressure, as was shown in this paper that lays out the potential mechanisms with high blood pressure over a long period of time, resulting in increased left ventricular wall thickness and stiffness, diastolic dysfunction, and in the end, left atrial enlargement and cardiomyopathy, which then is a risk for development of atrial fibrillation. So there's a clear cascade that develops over time, particularly when you have high blood pressure from young ages onwards and hypertension is uncontrolled. And as was shown also, they share so many risk factors. So in terms of obesity, genetic predisposition, sleep apnea, inflammation are all risk factors for hypertension, but also for atrial fibrillation. Hypertension leading also then to the development of atrial fibrillation, and we have many of these shared outcomes in the bottom box there. What is also of interest is that if blood pressure is well controlled, as in this study shown intensive blood pressure control, there's a lower risk for the development of AF. So that is should be a logical result, but it is very important that this has been shown. So again, emphasizing the importance of detecting high blood pressure and controlling it. Right, so we have established all of these relationships now, and the key thing I think that we should take home is the importance of detection of high blood pressure, detection of atrial fibrillation, and early management to ensure that it doesn't result in this long cascade of cardiovascular outcomes that we see. So the screening for both high blood pressure and AF is essential. And the key for that is, of course, both are asymptomatic. So it's not something that the patient would often come to a clinic for, and if it's not detected, it can't be managed. So in terms of screening for both conditions, of course, screening for AF is not recommended for all adults, as is the case for hypertension, due to the lower numbers. So it's a bit more tricky in terms of screening for AF, and the debate continues. Because screening is costly for large population studies, it is wondered whether there should be targeted case finding, who should be screened, because it's asymptomatic. So there's several trials ongoing to determine what would be the best approach. But at the moment, the World Heart Federation roadmaps recommend opportunistic screening for AF with pulse check or ECG in those 65 years and older, and hypertension in adults. So just a brief update on what we have experienced with My Measurement Month initiative, where there's a sub-study where we did some screening for atrial fibrillation together with hypertension. I'm sure most of you are by now familiar with what My Measurement Month is, but it's a global screening campaign that we launched in 2017 as part of the International Society of Hypertension. Millions of individuals have been screened to date, but in 2021, it was decided to do a smaller sub-study and to do concurrent blood pressure and AF screening. It was piloted in a subgroup of countries, and in 2023, we had 14 countries which participated. What we've done in these studies was to include specific devices, such as these Omron models, which can include screening for AF together with blood pressure, so that it doesn't take any additional time and resources, but it's basically two in one. And so we've, in all of these countries listed, these devices were used. And we also collected additional information from participants about AF, whether, firstly, whether it was detected, obviously, and then also whether the participant have previously had a diagnosis for atrial fibrillation. And just very briefly, the numbers obviously is much lower than what we would typically see for hypertension, but clearly an age relationship there, where we detected more individuals from 60 years onwards with AF. So, how to screen for AF, and I would like to acknowledge again Konstantinos and George's work here in their team on atrial fibrillation screening in this very interesting systematic review and meta-analysis on different devices, automated office, home and ambulatory devices, for using these devices for screening for AF. And so they evaluated several studies. And I think what's really relevant there is that it is recommended, as we know, and that these devices, which are already widely used in clinical practice for the diagnosis and management of hypertension, can also be effectively used at a low cost for highly accessible tools for also screening for AF at the same time. So there's good reliability in using these, and I think implementing them is an easy way to actually do both in clinical practice, but also in terms of home devices. Several measurements or devices can be used for screening at the patient level, healthcare level, for outpatients and inpatients. We have lots of wearable devices and phone apps that can these days also help detect AF, but also for home devices, the oscillometric cuff can obviously also do 2-in-1 blood pressure and AF, as well as in the clinic, together with ABPM. And that's why there's no need for additional time if there's already one device that can measure both, as was also concluded in this study. So let me conclude. It's not really to screen or not to screen. It is how is the best way to do this. And I think there's been a lot of uncertainty and additional measurements in terms of ECG that were done before, not as if this is a method that will replace ECG, but in terms of crude screening, it's a very effective way of using time to detect those at risk. So who to screen? As I mentioned, according to the latest guidelines, opportunistic screening for both AF and hypertension are recommended in people aged 65 years and older. Or however, if you have a device that can do both, it can be used in everyone. And as for also for AF in patients who already have hypertension, it's important to do screen for AF because they obviously have increased risk already, and other comorbidities such as sleep apnea, prior MI, heart failure, COPD, CKD, obesity, and diabetes all put them at an increased risk also for AF. And of course, traditionally by pulse palpation, ECG is a standard and routine way of doing this, but it's not always possible to do it for all in primary care. And then, of course, AF detection algorithms in validated Gov-based monitors is indeed appealing to also save time. But we need to still, for AF screening, do more research in terms of what's the most effective approaches. And I know the AF screen group especially is particularly spending quite a bit of time on finding the best strategies to implement. Thank you.
Thank you, Alta. Let me invite all the speakers to come up here for the discussion. We have 10 minutes, so if there is any question from the audience. If not, I might start maybe asking you, George, you discussed about nocturnal hypertension. Then what's the best way to make a diagnosis of nocturnal hypertension based on your data and your experience?
I think the So the most widely available and classic method is ABPM. The problem is that 24-hour BPM is not enough, particularly if you are looking at nighttime blood pressure, because there are fewer measurements and this is less reproducible than 24-hour, than the average 24-hour. So the classic is ABPM. Home devices is a solution for wide use, and the main advantage is that the protocols used are not based on a single night. So you have 3 readings today, 3 readings tomorrow, 3 the after day. So if there is any problem with one night, it will be diluted within the 3 days in some way. I think these are the solutions we have for the future. If we have cuffless devices, it will be wonderful, but I don't see them coming anytime soon.
Now, if this is a problem, then we need to consider treating nocturnal hypertension. Then a question for Professor Bilo. What about the bedtime dosing of drugs? This might help in non-dippers, and could this be in a way interfering with sleep?
Well, as you know, the data in this regard are not exactly going in the same direction. We have different studies saying different stories. The recent large trials do not indicate, at least in terms of outcome, any advantage of the bedtime dosing of medications. So for the moment, we do not really have a clear strategy about how to address this issue in terms of therapy. Many clinicians will still do this kind of chronotherapy, but the evidence base is not very strong. So surely we have to start to long-acting drugs, all these things that the guidelines will tell us. But what is, I think, more important is that if we identify a non-dipper, we also have to do some clinical reasoning in diagnostic terms. So we have to think about whether this is a person who has any specific reason for being non-dipper. Maybe it's a person with sleep apnea, maybe it's a person with hyperaldosteronism, maybe it's a person with renal insufficiency, and then of course this lets us understand this patient better and maybe also adjust our treatment strategy to this specific situation. As you know, for example, for sleep apnea, if we treat severe sleep apnea with CPAP, we gain some benefit in terms of nocturnal blood pressure reduction. It's not huge, but in non-dippers, as meta-analysis by Martino Pengo has shown, if you are non-dipper, the expected reduction is larger. So it's important to understand the actual cause of non-dipping in this case.
So as always, we need to personalize treatment. George, please.
Of course, the idea is not only to look at nighttime blood pressure, but to do something about that. And I'm afraid the issue of bedtime dosing has not been answered because it has not been properly addressed. The studies are great that we have them, but what they did, they give all the drugs in the morning, all in the evening to everybody. This was not the question we had. The question we have is if we can define nocturnal hypertension non-dipping, in these patients, whether nighttime blood pressure will make a difference. And we don't have the answer to this question. We don't have daytime.
Also because we have different phenotypes. Those who have only nocturnal hypertension, those who have daytime and nighttime hypertension, and this implies different pathophysiological mechanisms, possibly also a difference in the choice of treatment. But that's not the only problem. Alta, you were mentioning arrhythmias. Well, we know that hypertension is associated with atrial fibrillation. It's not a new finding. Nocturnal hypertension as well as daytime hypertension does it. The problem is what could be the combination of comorbidities that might facilitate appearance of arrhythmia in those with the nocturnal hypertension?
Yes, Gianfranco, there is indeed a lot of evidence that show that people with sleep apnea, it's been mentioned here several times, sleep apnea, sleep disorders, snoring, they are all associated with atrial fibrillation and with nighttime nocturnal blood pressure. So they could share, of course, some central similar pathophysiological pathways such as sympathetic overactivation. So there is indeed these links, but based on larger scale data, there also daytime blood pressure is predictive of atrial fibrillation. So I think important to try and treat as much as you can in terms of these additional disorders if it's detected, because it may lower the risk. But nevertheless, we should still screen for atrial fibrillation across all these modalities of measurement.
A very simple message to take home is that cardiologists, hypertensivologists should also take care of heart rate, not only of blood pressure. That's a simple message, which is not followed so often, unfortunately, because the behavior also heart rate can be a very nice screening approach for detecting something behind, including a sympathetic activation, which is one of the factors. And there is another issue that is important there, and that's what is the best technology that might provide a compromise between accurate blood pressure measurement and less disturbance of sleep when we measure blood pressure? We discussed the cuffless, the cuff-based. I know there are also some hybrid devices that might be kind of compromise between these two possibilities and help us out maybe to reduce the interference with sleep by providing reliable values at the same time. Any experience, George, in this direction?
I'm not convinced how this hybrid technology, which looks challenging, it will help in diagnosing. I don't understand how it can happen. I don't see this scenario. It's interesting as a research tool, to give it to me to see how it behaves, what information can I get. But in terms of detecting nighttime blood pressure, as long as I'll have these measurements every 20 minutes, I have the diagnosis. So, and if this diagnosis is in disagreement with the cuffless, I'll probably discard the cuffless. So I'm not sure I see that as an investigational tool.
Yeah, because the big issue is how to pick up the fast changes in blood pressure. If we are just using intermittent measurements every 20, 30 minutes, we are, of course, picking up some important change in blood pressure, and we have also the clinical data in support, but we are certainly missing the fast changes as shown by many experimental studies, and mainly the fast variation that might be associated with sleep apnea might not be picked up enough. So that's why there might be a need to try to get more to the details, and I don't know either whether this is the solution or not, but certainly we have to work in this direction. In the old times, we are using the intra-arterial approach, which is not clinically feasible, obviously, although we're able to see all these changes, and they're quite frequent and quite important, and we don't pick them up with the classic oscillometric approach.
But if you think that with ABPM you need to do it twice in the hope that the two recordings agree, how often it will happen. So the only solution, if you want to have wide assessment of nighttime blood pressure, is low-cost home monitors, which can do it. But I want to add a comment about the AF screening, very short one. It's something we forget. We used to measure blood pressure with auscultation. In this case, when the measurement is taken, is atrial fibrillation is present, we'll pick it up. Now with electronic devices, a patient with AF asymptomatic scar in our clinic has an atrial fibrillation, he is not diagnosed, he leaves the clinic undiagnosed. So because of these automated devices we are using now, I think all elderly people who need to use a blood pressure monitor, which means probably they are hypertensive, they must have an atrial fibrillation detector.
Marcus?
Yeah, a question to George. You did highlight the poor reproducibility of nocturnal blood pressure with an ABPM, yet obviously you get a good number of readings during that period, as opposed to the 2 or 3 readings you may get with a home blood pressure. So from a practical, for a simple clinician who wants to diagnose, are you suggesting if you have an ABPM which shows nocturnal hypertension, that needs to be confirmed, let's say with a home blood pressure over 2 or 3 days, and vice versa? If a patient did not want to have an ABPM, you give them a device, they measure it, because that will, be a tremendous additional burden for people now to have 2 means of measuring. I trust the ABPM when I get it. When I see nocturnal hypertension, I deal with it. And at this stage, at least, I'm not trying to confirm it. And obviously, if we use another means, that would be okay in my view. But that would have, substantial implications if we were now to say we have to confirm that diagnosis based on a gold standard, as we all agree, which is ABPM. So how do we deal with that from a practical clinical perspective?
Let's face the facts. If you have nocturnal hypertension today, and if you slept well, and if the device was used properly, if you do it next week, you have 30% chance not to have it. That's what it is. We can say that. So it's quite tough to be sure that this patient is really.
What I was just, because I had the same thought when you presented that again, George, and I was just thinking, if you look at the data from the Spanish registry, those people probably had only 1 ABPM, and those nighttime blood pressure strongly predicted outcomes. So I would
and there was only 1, so this was not a repeat. There was a single.
This is if you have 1 single reading anywhere in 1,000 people, it's a very powerful predictor. If you want 1 reading in an individual, then it's nothing.
Sure.
In
so
59,000, even better.
Together,
no, but you're right.
But I think this is an important question to address for those clinicians, who will have to make a call on this. Do I believe this or not? And I'm a bit concerned that we put in doubt what we consider the gold standard. Yes, reproducibility is an issue with office readings anyway, with home, with ambulatory. My concern is that we are kind of introducing mistrust in what we consider the gold standard. And I think we have to be very cautious how we deal with it.
Well, that's an important point, but if you look at available data, you find that the reproducibility of nocturnal behavior of blood pressure is much higher in those who have a problem. So if you have diabetic patients, CKD patients, the non-dipping is quite reproducible. In normal people, as George said, it's not. We have 40% variability in our experience. Also because sleep is not reproducible. We are not sleeping in the same way. Even if you use home blood pressure over repeated nights, we found a lot of variability because you sleep differently. And that's a complication of physiology that we have to accept. But nevertheless, you have to keep trying to be more precise. I agree with that.
And the same applies, of course, to masked hypertension, which for many colleagues out there is still very difficult to grasp. Where is this coming from? And again, that may have, of course, a similar explanation. If the day blood pressure is perfectly normal and you have masked nocturnal hypertension, is that simply an artifact? Who knows? And you know, that's kind of the uncertainty we're instilling out there with those cases. They are frequent enough, but I think we have to learn more research. And again, the studies you mentioned that needs to be done are very important in that context.
So in practice, if you have a non-dipper and the technique was applied properly, you probably are not going to repeat, because you are not going to treat nighttime blood pressure. But probably you'll see the whole profile, the average, maybe you need, because you are not going to treat nighttime, but you see maybe it's a borderline control all the 24 hours, you have other information, how high risk is this patient, and maybe you'll become a little more aggressive. That's what can happen for the present
Last
time.
question.
Yes. Professor Parati and Professor Bilo, as specialists of blood pressure variability, don't you think that during nighttime the variability is lower and you switch, as you told, from to a hybrid mode and make one calibration at the beginning of the sleep, and which will switch from cuff to cuffless mode of blood pressure measurement? Measurement during nighttime will be less disturbing the sleep and a more ideal, optimal way.
Okay, so if I understood correctly your question, you mean whether the use
the cuffless for variability.
yeah, basically that's what I understood. So, well, we don't really know, I think, because we would need to have comparative direct comparisons. I don't think it will have such a huge impact. Then obviously you are talking about two different approaches. With conventional ABPM, you have discontinuous monitoring every 20 minutes if we stick to the current recommendations. With the cuffless devices, you can have different settings, so different frequency of measurements, and this can influence. Then if you go to home measurements, you will probably have higher, actually I think there was a presentation at this Congress showing that there will be higher variability because you have fewer measurement points. So I don't think these are comparable estimates. Then if you go to cuffless, then the point is also that most of them do not give you continuous blood pressure value. So they still give you spots, and again, this will be quite difficult to compare with ABPM. I don't know if Professor Parati has any additional comment.
Thank you. I think we have illuminated the night a little bit, but we need more lamps, I guess. So as you see, there are many pending issues that we have to face, and that's space for research actually in this fascinating field. So let me thank my co-chair and all the speakers for their excellent talks, and you for participating, and wish you nice continuation of the Congress.